Hello, everyone. I'm Anna Plotkin. I'm the president of the Ontario Association of Pathologists, and welcome to the first virtual Ontario Association of Pathologists meeting. I think we live through the challenging times, and I really appreciate the opportunity and technology for being able to connect with all of you. This year, we decided to hold 3 lunchtimes meeting from Wednesday to Friday to make it easier for our members. This meeting would not be possible without the support of all the board members, and I would like to ask all the board members quickly to introduce themselves to the rest of the membership. And I see Corwin first in my screen. Corwin, please go ahead.
Hi, I'm Corwin Rousel. I'm the VP of the OAP and a pathologist at Unity Health Toronto.
Ardit?
Hi, this is Vidalisi. I'm the Secretary of Treasury and the Gabriel Services.
Andrea?
Hi, I'm Andrea Gran. I'm a pathologist in Kingston. Welcome.
Nancy? Nancy, you have to unmute yourself.
Hi, I'm Nancy Lee. I'm pathologist at Oakville Hospital, and I'm also the education director at the OAP. Hi.
And the rest of the board members will be joining us soon. And also our management company and them, especially Heather Doe, Meredith Slack, and Claire Running. I would like to thank all these people through their dedication to the Ontario Association of Pathologists. And of course, the meeting would not be possible without suggestions from our members. We value all your comments that you provide. I would like especially to thank Peter Borer Group for their input before this meeting. Please continue to communicate with us and contribute to the organization. Without further ado, I will ask Corwin to introduce our first speaker. Please remember to fill out the evaluation for each speaker, and at the end you will get your CME form. Please type your questions in the chat box. You can chat with me privately as well. Enjoy the conference, and I'm looking forward to seeing you all tomorrow. Corwin?
Thanks, Anna. So it's my pleasure to introduce our first speaker, Dr. Victor Tron. So those of you who know Dr. Tron know that he is very social media savvy and is very active on Twitter. So it's no surprise that the bio that he sent me is about half a tweet worth of text. But nevertheless, we know him very well from his academic leadership roles in Kingston and Toronto, as well as nationally in his leadership role previously as the president of the Canadian Association of Pathologists. So currently, Victor is the medical lead for dermatopathology at Life Labs. And most importantly for this presentation, he is section chair of the OMA Lab Medicine section. So Victor, we're very much looking forward to your update.
Thanks very much, Corwin. And is Heather, can you put up my, oh, here we are.
If you
Right.
simply share your screen, Dr. Tron, it'll pop up for you.
Sure. Okay, thanks very much. It's a pleasure to make my presentation today. You should know that the section has been very busy of late. I have no conflicts to declare. So today's outline, briefly outlining who our executive is, our council, and our tariff committee members. We have an update on the AFP, which we think is very promising at the moment. I'll give you some idea about where we'll be going with future negotiations. Of course, we have to mention work being done on COVID-19 and in particular what the section is doing on that. And I hope to take some questions. I hope there are some questions at the end.
I don't know if your screen is being shared. Is that,
hello?
Is your screen accessible? I don't know if I can't see it. Can it?
Yeah, sorry to interrupt, Dr. Tron. We can't see your screen yet. So if you just go to share screen. That green button at the bottom.
Yeah.
Just choose your select.
Sorry.
That's okay.
And I knew there would be a glitch. Share screen. I'm sorry. Can you see it now?
Perfect. Just put it in slideshow and we're good to go. So if you just expand
Okay.
it, excellent. Thank you.
So anyways, our executive, I'm the chair, Dr. Joshi, who many of you know is the vice chair, Neil Davis, secretary treasurer, Dimo Devaris, the past chair, and Catherine Ross is a member at large. We have a large number of council members that help us move things along, and Brendan Mullen chairs the tariff committee. So the council members serve as a sounding board to the executive, and they're from different places in the province and different practice settings, and they're extremely helpful to us. The tariff committee addresses fee allocation issues, and we'll be talking a bit about that. They've been fairly busy this year dealing with a problem with the retroactive payment and our fourth year allocation, and we'll talk a bit about that. And both members of both groups attended our last Ontario Lab Directors Summits. So the section, sorry, I'll just move that. So the section has been pushing quite hard over the last number of years, and this has certainly been one of my key issues, is developing a new alternate funding plan. And this is something that would replace the really inadequate two-stream funding mechanism referred to as LMFFA. Just gives me palpitations mentioning that word. Our persistent efforts, we think, have been met with success. The Physician Services Committee that encompasses both the OMA and the ministry has struck a subcommittee that will be developing an AFP, a new AFP for lab medicine and other specialties. So we feel that we've made great progress in this regard. High-level discussions with the ministry have just begun, and this will take some time, but I think this is extremely promising, and I think many of you will be happy with this. So the key foundational anchors for our AFP is that we need to accurately capture and measure all of the work you do. And this is important from a funding and in turn for an accountability perspective. We think we're a lot further ahead than many of our specialties. For example, work to quality, which was a tool that was put together a number of years, is actually an outstanding tool. And Dr. Joshi is spearheading an effort to update this vital tool. We also feel that the standards to quality practice guidelines will be led by Kathy Chernenko, and this is another important tool as key foundational anchors for our AFP. So in addition to this AFP, which we feel confident that we can move it ahead, we have some negotiating asks in the 2020 cycle. So we provided an update to the OMA Negotiations Task Force, which is the new name for the group that's leading the negotiations for the OMA. Basically, based on our assessment of workload increases over the last, let's say, 8 years, and that's when the last time we had funded positions, we feel that we feel that 80 new positions would be appropriate. Listen, give me 1 second. I need to give my computer a bit of juice. The battery's going on it. I'll just plug it in quickly. 1 second, 1 second. Great. We would like to raise the unlock and beyond what we get through the PSA. So we feel that Ontario is not competitive right now with other provinces. We used to be in the top third. I'm fairly certain we're in the bottom third in this regard. So even though we do get increases through the PSA, we do not think that is sufficient. So we're going to try to raise that, and using provincial comparators is a useful thing. And we're also going to modernize the OHIP schedule of benefits. And this is something that we've been doing on an ongoing way. And we want to bring it in line with the AMA CPT codes, which is something that we use in terms of relativity, and we think it works extremely well for our specialty. So the 2019 brought in the arbitrated award, the Kaplan Award, and there were a number of retroactive payments, hopefully that many of you already have received, and the percentages you're well aware of, and hopefully this has all gone reasonably smoothly with your finance departments. In year 4, there's a permanent compensation increase effective April 1st. We also saw 15 of our undervalued OHIP fee codes go up, and this was mailed to all members in April of this year. Unfortunately, due to a snafu or whatever by the ministry, we were short by $940,000. So we immediately whipped into action and began working with the OMA negotiations to address and reverse this. And indeed, the ministry has agreed that this was an error that they've made, and is now working its way through the internal ministry approval process. So again, these are the OHIP codes that we increased, and for example, some of those, one of those is the consult code, another reading blood films, etc. So these not only impact work done in the commercial lab, but also work done in the hospital sector. So some of you have asked about the correct UMLUC rate moving forward. And so the correct UMLUC rate for 2021 has been updated, and it is 367,490. And this is the number that you should be getting. And it's something that your finance department certainly should know about. COVID-19 has been a major concern to everybody, and it's hit us in a number of ways. We've had to work in challenging circumstances. So we've been advocating for additional resources to boost COVID-19 testing, trying to make approval testing processes easier. We've asked for and obtained deferral of EQA by IQMH during COVID, and we've pushed hard for pandemic pay for laboratory medical technologists, and unfortunately this has not been that successful, which is true with a number of specialties. I think the government really dropped the ball on this. We've been put a big focus on income stabilization for various effective specialties, and this has worked better in some than in others, and it did not actually work all that well with lab medicine. These monies should have flowed to people. I don't think many people received this, and this is for those that had OHIP billings, and this was a way of income stabilization. This money, as it turns out, would have to be repaid. So people are kind of, some people think it was a good idea, others not. We held 2 special virtual meetings with Ontario lab directors regarding COVID-19, and people were able to talk about their concerns. And the big concern, of course, is ramped up deferred services. There was a committee struck by Ontario Health and chaired by Chris Simpson from Kingston to develop some guidelines. We initially saw the document and saw there was no pathology representation. So again, we had to advocate for someone to be involved. And as it turns out, with some back and forth with Dr. Simpson, Dr. Aaron Paulette was put on this committee and the successor to this committee. And we believe that Aaron, in his many multiple roles, will be a great advocate for allocation of resources to lab medicine as they ramp up deferred services. So April's Lab Directors Summit focused largely on COVID-19. Several lab directors presented their insights and strategies and how they feel that the value added we bring to the table needs to be discussed. I mean, some of the key takeaways, and we all do this, you have to be tenacious and inject lab medicine into any discussion you can. Developing good internal relationships, of course, is always important. Protection of lab resources is important. We worry that, you know, as budgets get targeted post-COVID, we don't want to be a center that gets trimmed even further. We need more money, not less money. So there are various things about OR scheduling, et cetera, but I would have to say that the lab directors summits have been very good, and we have some plan going into the future. We're just working out those dates. So I do have some time, I believe, for questions. I babbled on a bit too long, but I'm happy to take a few questions.
Yeah, so thanks, Victor. Actually, you're right on time, I think.
Okay. Yeah, we go till 12:30. Yeah, yeah.
Yeah, and we actually have the luxury of a little more time because the introduction was short. So I see one question so far in the Q&A, and so any others, please, this is your opportunity. Please feel free to submit more questions. So, hi, Victor. The AFP, as described, focuses on pathologists. How will it manage workload and staffing for the other lab specialties?
Yeah, and that's something that is really high on our list. It's a lot easier to do anatomic pathology because basically, for the most part, you're counting widgets. But of course, remember, we're also going to be including things like tumor boards and that sort of thing for the pathologists. We're going to be reaching out to the various subsections, med micro, medical biochemistry, and what have you, to assist us in developing the appropriate guidelines and workloads for non-AP specialties. So this will be part of the process that Suhash Joshi's committee will be working on.
Thanks, Victor. Now, perhaps I missed it, but have we sort of decided or recommended a particular workload measurement tool for pathologists? As you know, there are several out there, notably the CAP L4E and the, of course, Ontario-based W2Q.
I think we haven't, and in part, you know, the ministry might dictate this a bit. I kind of feel we have to make sure we have a workload measure that works for Ontario. I would have to say that the CAP tool, in our estimation, even though they're relatively close, the differences between Ontario and the rest of Canada exist. You know, we're hoping that we can create something that works best for Ontario pathologists. And, you know, I personally feel that W2Q is a good one. But at the end of the day, you know, government will have to be part of this discussion. We hope to convince them that whatever tool we put forward is a good one and a fair one.
Okay. I see another question actually coming through the chat line. So this is a question about whether we will be able to, as pathologists, to bill for cases discussed in the tumor boards in the same fashion that the clinicians do.
So that is really a great question. And I think so remember, many of the clinicians that go to the tumor boards are fee-for-service physicians. So they need they feel they need some sort of compensation. They get some sort of compensation. We feel that the best way to address this is to include it as a workload measure. So, so with the AFP, depending on how it's going to roll out, all of those, all of the workload, for example, your group will be doing will need to be appropriately compensated, and that money flow to the group. I mean, that would be my preferred solution. And so those dollars, if you can, show that, yeah, we did this, we did that, that all be put into the workload hopper for the group. And in doing so, you would get paid then.
Okay. And I see another question. What is the anticipated time frame for the implementation of the new AFP?
Well, as you know, the ministry works in mysterious and slow ways. When was LMFFA was put in place in 2004, and basically was kind of an interim thing. So in 16 years, and we've been pushing hard for some sort of replacement, we don't think it's going to take another 16 years. I think there's a lot of push from, for example, from CCO with support through the Ontario Hospital Association. I don't even want to put a date. I think if it goes smoothly, this is going to happen sooner than many people think. I think some of the potential stumbling blocks might be, what we decide on what an appropriate workload is for one FTE. That sort, and what is a workload measure? I mean, a lot of these things are workable, but they do take a bit of time.
For sure. I see another question about is there any plan to advocate for shadow billing for pathologists similar to oncologists?
Yeah, well, that would be just fine, but we don't have a modern OHIP fee guide to do that. So really, shadow billing, I think, would be inappropriate for lab medicine. I think we don't need to do shadow billing if we have an appropriate workload tool. So so it would be difficult on a whole bunch of fronts, and I don't think we should be going down that road, to be perfectly honest. I don't think it would be ideal for us.
So basically, you feel that the at least one of the workload measurement tools that we have would probably be a better way to go rather than shadow billing.
I do. I think that shadow billing. I had with my time in Kingston, I had the good fortune of sitting on the CMO Resources Committee, and I got a good feel for what would work for example, surgery medicine versus what would work for lab medicine, and I just don't see that working.
Victor, some people asking what is it shadow billing? Can you explain, please?
So shadow billing, basically, for those groups that are put on an alternate funding plan, government wants to know that they're getting their money's worth, so to speak. So basically, as you do your services, let's say in Kingston, you're working at Kingston General Hospital, you're providing your services, but at the same time, in the background, the accounting types are basically determining, how much would you be billing through OHIP, and so for the most part, government wants a certain percentage of billings to show that they're getting their money's worth. So that's the shadow billing concept. Yeah, and it works quite well for some specialties.
Okay, so I see actually questions and comments are now starting to flow. I think people are getting into this. So I see a comment from Suha saying that you know, several workload systems were compared and were at par, and that we should be using the W2Q going forward for workload metrics. And I think the exciting part here is that the second version will be created shortly. So any timeline on that?
You know, Suhash can maybe just read a little comment, but I think we're really fortunate to have Suhash leading this project. I mean, he knows that document back to front, and being a very active pathologist and leader in lab medicine, I think that that document is going to be an absolute winner for our specialty in Ontario.
Terrific, and we all know how much work goes into creating that.
Oh no, it's that's a lot of work. I mean, that's, you know, that's, but I think, you know what, Suhash is a hard worker. He'll roll up his sleeves and he'll pound it out.
Fantastic. And I see that he says we'll have it by the end of the year.
Okay, so like
sort of yeah, so sort of changing gears. I see a question here that okay, Rob Ford says he wants to start surgeries on the weekend.
okay,
Is the committee
that would be Doug Ford.
Yeah, correct. Is the committee that Dr. Pollanen is on the one that will advocate for us? Obviously, surgeries on the weekend may lead to frozen sections.
Yeah, I know we've had some questions around that. Absolutely. Now, I'm not sure, you know, how that those dots would be connected. I'm assuming that committee will be part of it, and with Aaron on that committee, I think it's going to be clear that that issue is going to be addressed. I suspect it's going to be a bit different from site to site, so this may not be one size fits all, but I certainly hope that there's guidance from this committee that, you know, if we put in a weekend surgery, this is not just, you know, ORs, surgeons, scrub nurses, this is also pathologists. So that's what needs to be brought forward.
Okay. And we have another question here. Does the retroactive payment also apply to fee-for-service work in private labs?
Yes, it does. And what's happened with that is, I don't want to get into all the gory details, but for some reason, the government decided that some of the fee-for-service work that was done by people that worked in the commercial labs, like yours truly, somehow was, I don't know, billed by the private labs, had nothing to do with physicians. It was a monumental screw up by the ministry. They've now seen their kind of, you know, I wouldn't say stupidity, but the ball that they dropped, and that's now being reversed. I'm hoping that we're going to see these retroactive payments for fee-for-service physicians, you know, October, November. I think Dr. Mullen, Brendan Mullen is trying to get his get some more information on this. But, you know, I thought we did quite well to have the ministry reverse their decision on this, because, as you know, sometimes when this happens, it's you know, bank error in our favor, and, you know, you can scream and shout all you want and you're not going to get anything. So Brendan did yeoman's work on this issue.
Fantastic. Okay, I think we can squeeze in one more question. And so I'm going to choose one here. Will we be able to maintain our membership in HOOP with the new AFP, and I'm sure that's of concern to a lot of hospital-based pathologists.
Absolutely, that has to be a given. I mean that, and we believe it can happen, depending on how the monies can flow. So there's I think a number of mechanisms. I think this falls into the details that need to be worked out category. But yes, that would be the people need to be able to stay in who. Yes.
Okay, well, I think that's welcome news to a lot of people who have invested in that for many years.
Yeah, no. We want people to, eventually retire comfortably.
Exactly. Okay, well, thank you so much, Victor, and we really appreciate. Okay, sorry for the interruption there. We really appreciate your time and sharing these updates with us.
And we'd like to hear from members, I think that it's trying times, but try to send us a note, send me a note, and I'm usually pretty good at getting back to people. If I don't have the answer, I'll run it by somebody. So yeah, I think things are, cautiously, things are looking up. So we'll just keep pounding away.
Thank you so much, Victor. That was great. And I really hope that members will submit more questions and we'll forward it to you. Yeah. So I'll ask Ardit to introduce our next speaker. Ardit, can you hear me?
Yeah.
Okay. Yep. Can you please introduce our next speaker?
Yeah. It's my pleasure to introduce the next speaker, is Dr. Michael Pollanen, Chief Forensic Pathologist of Ontario, of Canada, and Professor and Vice Chair, Innovation of Laboratory Medicine of Pathology of University of Toronto. He graduated from University of Toronto with an MD in 1999 and PhD in 1995, and completed his residency in 2003. His duties include supervising and directing the Ontario Pathology Services for over 7,000 autopsies a year, conducting autopsies, more than 2,500 autopsies to date, and testifying in court, more than 250 court testimonies. His interest is his personal interest is in Nodding syndrome in Uganda, and he's held a lot of forensic capacities in Global South, and has been involved in several cases on training missions in Algeria, Bermuda, Cambodia, East Timor, Egypt, Haiti, Iraq, Jamaica, and so many other countries. Dr. Pollanen has been a member of Forensic Advisory Board, International Committee of the Red Cross, and past president of the International Association of Forensic Science from 2015 to 2017. He's a founder of Forensic Pathology, Royal College of Physician Surgeons of Ontario, and he truly modernized the forensic pathology in Ontario. On a personal note, as a community pathologist, we appreciate a lot his promptness in consultation of cases and his precious opinion as well. Dr. Pollanen, thank you for accepting our invitation, and the floor is yours.
Thanks very much for that introduction, and good afternoon, everyone. Happy to join you on this meeting of the OAP as usual. I have a very brief presentation that I would like to share. I'll share my screen in a moment, but before I do so, I just wanted to give my thanks to the OAP and all of the pathologists that are practicing in Ontario at this very interesting time in our career, specifically We have lots of challenges with regard to the pandemic and the secondary effects that flow from the pandemic. And I really appreciate all of the work that everyone has been doing on our registry to keep the medical legal autopsy system moving in Ontario. And on that note, I will start my presentation. And can you see that?
Yes, you can see it.
Okay. So, my purpose today is to give you an update about forensic pathology in the context of the Ontario Forensic Pathology Service. I'm just going to start off by giving you some general information just to familiarize some of the individuals who may not know some of the details about how the system operates. The Ontario death investigation system is really divided up into two integrated collaborative components. One is the Office of the Chief Coroner, the other is the Ontario Forensic Pathology Service. As you know, the coroners in Ontario are medical doctors and investigate death under the Coroners Act. In about 50% of the cases that the coroners investigate, a medical legal autopsy is required to determine the cause of death and some other persistent or interesting questions that might be relevant to the death investigation. So the Ontario Forensic Pathology Service is a collaboration of pathologists and forensic pathologists across Ontario that are situated in community hospitals, academic health science centers in the form of regional forensic pathology units, and our main facility in Toronto, which is the Forensic Services and Coroners Complex. We have a strategic plan that is renewed every 5 years. It's actually coming due now. And I've just listed 5 of the main core objectives that we have in the Ontario Forensic Pathology Service. Obviously, our prime mandate is to contribute to death investigation using pathology and forensic pathology. In other words, one of the main contributions to death investigation via pathology is the autopsy. So that's our main contribution in the death investigation system is conducting autopsies. We are on this basis, we are dedicated to continually improving the quality of medical legal autopsies in Ontario. We're intensely interested and focused on postgraduate medical education in forensic pathology. Like other branches of pathology, we try to maintain high standards for the management of the samples that flow from autopsies, including organs, tissues, DNA, body fluids. And one of the things that is currently at the forefront in forensic pathology is exploring new technologies such as postmortem imaging. So these sort of represent 5 of our core main objectives in the Ontario Forensic Pathology Service. Now, I'm going to show you some stats because everybody's interested in stats and workload, but these are, and I'm going to narrate them a little bit. So let's start off with the first graph. And this represents the total provincial caseload over a period from 2012 to present. And you can see that back in 2012, we had about 5,700 medical legal autopsies in the province. And we are projected now at the end of 2020 to be around 8,800 autopsies. This is a huge amount of work in terms of caseload. And if you look at the lower graph, you will see a little bit of how the caseload fractionates out relative to the provincial forensic pathology unit here in our institution in Downsview, in addition to the regional forensic pathology units and the community hospitals. And you will see that the major trend has been that there has been an increase in workload in Toronto and a progressive decrease in workload in the community hospitals. You also notice that there is a decrease in workload in the regional forensic pathology units, which largely relates to redistribution of cases from Hamilton region to Toronto, as well as some other referrals that occur from Northern Ontario. I draw your attention to the decline in medical legal autopsies from 2012 to present being done in the community hospitals. This is largely because hospitals are refocusing their efforts outside of providing services of this nature. This is largely because the resources are being applied to the laboratory, other tasks in laboratory medicine, and also on a more practical level, a decreased availability of technical support in the autopsy room, either by morgue technicians or by pathologist assistants. So we anticipate that this trend will continue to decline over the next few years. Now, we have a quality assurance system in the Ontario Forensic Pathology Service, and I've shared with you some of the data from that, and I'd like to focus on a number of the different categories here. So first of all, I have to say that in terms of our quantitative quality indicators, we enjoy a very high quality in the work that's done in the province of Ontario. We have excellent pathologists and forensic pathologists in the province. And as a result, the quality of the medical legal autopsies that are performed are quite high. So if you use measures of completeness and consistency, you can see the statistics there, very good. In terms of peer review, we do extensive peer review of all high profile cases, including homicides. And for the most part, these reviews unfold unproblematically every year in the province. However, I will draw your attention to turnaround time. And I have a few things to say about turnaround time. This is a histogram showing the turnaround time of various autopsy reports by bins relative to caseload. You can see that it's a fairly long distribution chart. So in other words, it's more heavily weighted to the shorter time periods rather than the longer time periods. Our goal is to have a majority of cases completed within 90 days. We have the quality standard of 90% of autopsy reports should be finished in 90 days of autopsy. And you can see that's the solid dashed red line shows basically that standard. And so, basically everything left of that line follows within the accepted turnaround time category, and everything to the right of the red line shows the, outlier work, as it were. So and of course, there are various reasons why turnaround times may be prolonged, or in fact, the case may be finished more rapidly. These include things like case complexity, the requirement of ancillary investigations, and so on. So you can see there's a distribution. One of the things that we are looking at right now is whether or not our turnaround time standards are actually representative of what our work capacity is. So in other words, we're going to revisit whether 90% in 90 days is a relevant standard based upon the current pressures in the system. And we will do so by looking at actual empirical data to determine what turnaround time can be actually reasonably accomplished based upon the resources that are available in the system. I think that's an important point, and sometimes lost on people who are looking into our system, and that is that when I say our system, I mean even surgical pathology and other laboratory disciplines, that your quality parameters, your KPIs, can be aspirational, but they also have to be matched to the resources that are present in the system. So I think we are going to re-examine our turnaround times with that in mind. So we've been very busy in the last year, and we will continue to be busy in the next year or two with continuous quality improvement regarding specific standard operating procedures and other standards in the system. And just to sort of give you a bit of a historical view of that, we have had, since the Ontario Forensic Pathology Service was created about 10 years ago, we've had very good policy development, quality management development, but we're now in a period of renewal, looking at our various policies and procedures based upon internal and external factors, including review by the Auditor General and advice provided by the Death Investigation Oversight Council, as well as sort of our normal internal processes. So recently, 3 new SOPs have been approved by the Forensic Pathology Advisory Committee, including new procedures and standards regarding peer review of autopsy reports, how we should procedurally deal with non-conforming work. So in other words, where there is discrepancy in diagnostic opinion, and how does one deal with that within the context of registration of pathologists with our service? What is the proper relationship between our service and the CPSO in the context of non-conforming work? And finally, we have increased our standards around court feedback and obtaining input from the Crown Defense and witness with court appearances of forensic pathologists in the Superior Court predominantly. So there's a lot of work that's being done in the policy domain. I should also mention that one of the changes that we have implemented is that the quarterly Forensic Pathology Advisory Committee meeting will now, a portion of it will be open to registered pathologists to attend and participate in those quarterly meetings. And this will serve as a way of providing an update to the registered pathologists regarding various policy level activities that are happening in the system. So I thought I should probably spend a little bit of time talking about COVID-19, since this is obviously on the front of everybody's mind. And there are some frequently asked questions that I thought I would review very quickly. And I'm just going to go through this list here. And this represents the answers that we've given to these questions over the last few months. So one of the most common questions we get is, how long does the virus live in a dead body? The answer is we don't know, but there's no reason to believe that postmortem infectious risk is high. Unlike in some other pathogens like Ebola or other more virulent organisms. Should autopsies be conducted? Our position is that autopsies should be conducted under specific circumstances. Our position has been organizationally that COVID-19 represents natural deaths and therefore are not properly part of the death investigation system unless there is some compelling medical legal issue to be investigated in the case. For example, allegations of maltreatment in a nursing home with death related to COVID-19. Obviously, we accept jurisdiction on those cases and will perform appropriate autopsies on those cases. We also believe that under specific research protocols, that autopsies can be undertaken. How should autopsies be conducted? We've taken the position that it sort of depends upon the purpose, but we've opted for a minimally invasive approach whenever possible. We advocate for the use of a negative pressure room with precautions around aerosolization, which includes, for example, wearing an N95 mask, maybe electing not to open the cranium. And if you do elect to open the cranium or use an oscillating saw, to use the proper protections associated with that. Our current practice in Ontario is to do targeted postmortem examinations for medical legal reasons only, although we have left open the possibility of participating in a research protocol. And then with regard to disposition of the body, either burial or cremation is acceptable.
Sorry, Dr. Pollanen, to interrupt, but looks like it passed the time. Just need 1 or 2 minutes, please.
Okay. So just to finish up, I'm just going to show you a few pictures of some COVID-19 showing hyaline membranes in the lung and more extensive hyaline membrane formation, some organizing pneumonia, and in some cases thromboembolic pathology. So on that note, I'm going to stop sharing my screen, and I guess I'll send it back to you if there are any questions.
I think, Michael, probably in the interest of time, we will go with the rest of the talks. We're a little bit behind now, and I'll forward all the questions to you, because I'm sure there will be a lot of questions with regards to especially autopsy services in the hospitals, and I know you're doing some work behind it.
Okay, thank you very much.
Thank you very much, Dr. Pollanen.
Thanks a lot for joining us. We really appreciate your input. Thank you, Michael.
Okay, see you later.
And I will ask Andrea to introduce our next speaker.
Hello. So it's a pleasure to welcome Dr. Scot Bradshaw today to the meeting. Scott has an interesting background. He has a Bachelor of Science in Physics, and then followed that with a Master of Science in Electrical Engineering. He then worked for almost 10 years in the field of optoelectronics before deciding to go back to school and study medicine. He got his medical degree from Queen's University, followed by pathology training at the University of Ottawa. He then received subspecialty dermatopathology training at Harvard University, and then continued to work there for a period of time. So since 2016, Dr. Bradshaw has been back in Canada, and he's been working between Dynacare Labs in Ottawa, the University of Ottawa, and with us at Queen's University. So today, Dr. Bradshaw is going to talk to us about inflammatory skin for the general pathologist, practical approach. So welcome.
Thanks very much, Andrea. So as she pointed out, this is going to be the subject of the talk. I'm following all of my rules. Let me click here. Oops, all of my rules. I have no conflicts of interest. I was trying to think, normally I teach to residents and their objective is almost uniformly they want to pass the Royal College exam. This is a little different. You guys have kind of the same thoughts that I have. You want to make an accurate diagnosis. You want to maintain the confidence of clinicians, and really you don't want to get into court except unless you're Michael Pollanen or one of those guys. So the fortunate thing about my topic today is it's not really a thing that's going to get anybody sued. Inflammatory derm is a pretty safe thing. But nevertheless, we feel sometimes uncomfortable because it can be tricky or quite nuanced. So based on that and the different target audience, I've had to modify some of my lectures. And kind of the goal or the underlying, I guess, approach here is I'm going to try a different approach where I'm giving more common things and tips and things I've learned along the way that help me refine my approach to straightforward things like psoriasis or eczematous dermatitis, rather than getting into some crazy zebras, which tends to happen at these talks. So one of my favorite quotes here is, uncommon presentations of common diseases is more common than uncommon diseases. It's a mouthful, but I think it's kind of a principle we need to keep in mind as pathologists and all of medicine. So with the target audience in mind, these are the learning objectives. I try to keep it down to like 2 or 3 things. It's mainly targeted at people who don't have specialty training in dermatopathology. So what can you sign it yourself, feel pretty comfortable? Honestly, any inflammatory, you're giving an opinion, you're helping the clinician. I'll try to give you some more tips to feel more comfortable in stuff you're keeping. Second, what things are common and what is uncommon. So if things are uncommon, maybe you don't have to keep everything in-house. And then especially, so in all of pathology, but especially in dermatopathology, and especially in inflammatory dermatopathology, a lot of the diagnosis depends on clinical correlation and how much information the clinician gives you. So I'll try to give some guidance on how you can approach that. And that kind of leads into objective 4 is, if they don't really give you much information, feel free to lump and give kind of a category for your diagnosis, rather than trying to go out, stick your neck out and give something specific. So with those objectives, I'm going to backtrack and give an outline and all the rest and be quite formal and organized. But just to get started and get our feet wet, let's use the chat window. I've got it up on my screen so I can see what you guys are writing. And I'm just going to throw some cases up and we'll try to do it. So my view is you can always look at the slides on your own. So me running through the slides and talking isn't really as helpful as you getting a chance to look at things. So this has worked well with me giving to residents who are 5 or 6 residents at a time, but I don't know how well it's going to work for 120 people, but we'll see what happens. So here's a inflammatory skin thing at low power. Anybody have any thoughts at low power? What pattern are we in? Psoriasiform, just go into the chat window if you have any thoughts here. Try to get everybody to wake up, pay attention. Here's a high power photo of the same thing. So I chose this case and the residents actually got a little frustrated when they, yeah, spongiotic is kind of my thought. Spongiotic. The reason I chose it is because there are some features that might make you think of the psoriasiform pattern. There's kind of a parakeratotic scale. It's pretty dry. Vasculitis, we'll take a look. It's hard to see what's going on down here at these powers, but it's a good thought to keep in the back of our mind. And I wanted to choose a case that's purposely got some mixture of features. And yeah, there's some spongiosis, even maybe an incipient spongiotic vesicle starting to form over here. But if we put on our hat for psoriasis, there's some things we could try to see to support that. The granular layer out here has been kind of reduced here. There's the dry scale I mentioned before. There's acanthosis, which we think of as a feature of psoriasis, but in this case, it's not a super regular acanthosis. So I tend to look at these slides without looking at the requisitions to get an idea of what I think is going on before I get misled by the clinician, and then try to guess what he's going to ask about. And when I see this, invariably what the clinician is asking, is this psoriasis or eczema? So I think people have already kind of pushed towards an eczematous process, and I kind of agree with that. But there is kind of a mixture of features, right? There's some psoriasiform features. And one of the things that I wanted to bring up is when it's not that easy to place perfectly into one box, one of the things I learned along the way was think of a drug reaction. So along the lines of looking at what's happening in the dermis here, you see a lot of eosinophils. I don't think there's really vasculitis going on. There might be a couple of extravasated red blood cells, which actually is another feature that makes me think of a drug reaction. If there's just a little bit of vascular irritation. So the other thing that I notice when I'm an attendee of some of these talks is it's all well and fine to give your thoughts and describe things, but I find it useful to see how other people report stuff. So I've left in the report here, you can go over it on your own, some sample dictations that I would give for some of these things, and give you something you can throw it all in the garbage. You can read it through and take bits and pieces or do whatever you want. So in this case, I wouldn't straight out say this is spongiotic dermatitis. There's a little bit of psoriasiform. I wouldn't say straight out it's a drug reaction either. I try to be perfectly accurate up here because this has to stand the test of time for 20 years, as I'm sure all of you know as practicing pathologists. You say something you think is true today, and then a year goes by and something else happens to the patient, and now your dictation doesn't look so great anymore. So I leave my conjectures to the very end, and I'm careful to couch it in with only as much as I'm willing to guarantee is there in the pathology. So we went over a few of the features of that case, which was kind of a mixture of things, and I raised the possibility of a drug reaction. As I said, I've got a lot of information on these slides. I'm not going to go over the slides so much as spend time on the pictures and talking about them. You can always read this later. The other thing I think about when I'm the one as a participant in these lectures is I enjoy the talks and I'm having a good time, and then I get to my evaluation and I think, oh, I forgot to remember how I'm going to change my practice or what I learned from this lecture. So throughout, I'm going to give you some hints here that kind of spoon feed you some answers. So I promised I'd go back to an outline. Here is all of skin pathology. My favorite reference is Whedon. And in fact, when I was in Boston, almost everyone I studied with, and there were 20 or 25 people there that I worked with, and they all used Whedon. And even though there's many, many textbooks for dermatopathology, I think it's because it's a very complete discussion of most entities. Unfortunately, we can't really cover all of Whedon. These are the sections of Whedon, and I've already said I'm going to limit the talk to tissue reaction patterns or inflammatory derm. And of course, infections comes in indirectly because they get they have certain reaction patterns that you might miss that it's actually an infection. So if I did that, we take from Whedon his breakdown of inflammatory skin. There's these 6 categories. And if we covered all of that, our outline would look like this. And I don't think we have time in 50 minutes, and someone's going to cut me off with 10 minutes to go. So I realized I have to cut it back a little further. And where I went was to try to cover more spongiotic psoriasiform and a little bit of interface. I'm not going to touch granulomatous and bullous, and some people may be frustrated thinking, oh, I wanted some more information on that. But the reason I broke it down this way is because when I review things or get referrals from pathologists, whenever it's granulomatous or bullous or immunobullous and they're wondering about the DIF results, I find I don't really add very much. Usually those things are handled. And the places where I can give a little bit more nuance is some of these things up here in the spongiotic and psoriasiform. Also, these are more common, and I promise that we'd be dealing with more practical things, right? Things that come across your desk all the time. And then again, along that list, when I made the talk and got all my entities that I'm going to cover in place, I realized there were 5 or 6 that I just wanted to say they exist because they're so common, and they are inflammatory skin. So I don't go over any entities there. I just provide a list at the end. And then I think it's good. I teach when I teach the dermatology residents, if you don't see anything on an exam and you only have a couple of minutes and you're panicked, just have right in your back pocket a list of invisible dermatoses that you just go through the list and maybe the light bulb will go on. You'll see one of those. So that's the outline. And this is kind of we always have an approach. So I teach residents an approach. First question, is this a tumor or not? And we go through many more questions, and eventually we get down to the bottom and decide it's actually inflammatory and it's in the epidermis. And we're down here in this miserable part here. And that's what I'm going to cover. And then over here, I promised a list of invisible dermatoses. So with that as an outline, here's some more pictures. Just checking my time over here. What do people think here as the reaction pattern? This is the interactive part. This is why I feel like I can steal a little bit from the 10 minutes at the end if we're interacting during the talk. Yeah, spongiotic. And in fact, there's not really much else except spongiotic, right? And there's maybe some superficial perivascular lymphocytic inflammation. So now you're all expecting, oh, let's see a sample report. It's going to have all this cleverness in there. So this is what I would put for that. Spongiotic dermatitis, describe that there's spongiosis and inflammation. If I looked at high power, I'd see a few eosinophils. And then I say it's not specific. There's a few ways that this can be handled, and there's a few ways that my mentors have handled this. They'll give a list of things that could cause this. But I worry when it's such a long list like spongiotic dermatitis that I'm going to miss one or two, and that's going to be the one that it turns out to be. So I just say this, and you may think, well, that's not very helpful for the clinician. It's very general. It doesn't provide any specific diagnosis, specific information. But when you think about it, is there excellent, 5 more minutes from Meredith, awesome. Is there really anything specific there? And being accurate is all we're really able to do. The other thing I wanted to say is I've learned going to these rounds that even though I felt bad about such a vague, non-specific report, the clinicians are super happy, and this is why. Maybe they thought this was mycosis fungoides, and I gave them a lot of help, or they thought it was an interface reaction. And just limiting them down and saying there's really nothing special going on here directs them very well with their treatment. So it turns out they actually are quite happy with that when it's accurate, and you don't have to give anything more. So don't feel pressure to get to something specific if the biopsy is very clear and that's all there is. Here's another case, and I know the diagnosis because I correlated it clinically, and I'm trying to decide if I could have come up with a diagnosis just on the histology. We'll see if you guys do. So this will be a good test. And low power, what do people think here? So I've done this a couple of times with some residents, and I know my timing actually comes in about 54 minutes. And people, well, the residents anyways, tend to latch on. There's a bit of acanthosis here. Yeah, psoriasiform. There's a bit of a dry scale. What are some features against psoriasis, though? I know it's not over here in the scale, but over here, do you see the granular layer a little bit not diminished, but in fact even accentuated? And also the acanthosis isn't super regular, right? These ones are deep near this follicle, but these ones are shallow. Yeah, no suprapapillary plate thinning, I agree. When I went to high power, I noticed the derm residents anyways got caught on this pale staining, which is just an artifact that we see sometimes when the epidermis is irritated. I don't know what causes that. Some people ask me that. If anybody knows, let me know. I think it's just an ischemic effect. No, yeah, there's not really neutrophils up there either. I'm trying to, also, as I say, I've correlated this, and I was hoping someone might notice that there's a follicle here, and this perikeratosis is kind of near this follicle, but not so much away from it. There's also a plugged follicle over here. Anybody have any thoughts what that might lead to? Maybe this is in the middle of the face, kind of a rash. Yep, seb-K is a possibility, PRP. I'm trying to go for seborrheic dermatitis, which when the perikeratosis is just perifollicular, and there can be some spongiosis, which is why it's kind of in this category. PRP is actually a good thought because it's a perifollicular perikeratosis as well with this alternating ortho and perikeratosis. So I thought of sebderm. As I say, I look at the slides first and then I look at the requisition. And in fact, the clinician, that was on their differential as well, and it was in the right location on the body. So this is my report for that kind of thing. Actually, lupus. So I don't like perikeratosis so much for lupus. And I want to see something like an interface. Now, having said that, sometimes there's just mucin and more of a tumid lupus, but we'll get into that a little bit later. It's a good thought. And again, I'm going to leave you with a sample report. Again, I don't think this is something you can diagnose histologically alone without a little bit of a clinical help. And remember, that was one of the learning objectives I had, right? So here, I'll leave you with that. Go on to another one here. This is a good one. My derm residents are always on top of this one because it's one that can go up on their exam. It's not as common, but it happens. So the pattern, first of all, everyone, spongiotic, psoriasiform, interface, something else, vascular. Yeah, spongiotic. I agree. What about the scale? Anybody? It's so my poster child perfect scale for spongiosis would be a wet scale. This scale is a little bit dry. And with the eye of faith, does anybody think it's not really uniform scale. Maybe there's a little mound over here, another little mound over here. Yeah, there are a couple of eosinophils actually down there. There's some red blood cells too, not in this photo, but maybe in some, actually there's maybe a couple in here. Mounds of parakeratosis, yeah, that's what we're getting at. Sometimes they lift and give a little tea kettle appearance. So, and the basic category of pityriasis rosea is that they're spongiotic, a bit of lymphocytic inflammation, and then these suggestive little mounds of parakeratosis. But again, I wouldn't put it in the diagnostic line, the same diagnostic line as I've used throughout. The main thing that's happening here is spongiotic dermatitis. And then in the bottom, after I've described everything accurately, I say, oh, I'm going to lead into just raising one possibility. And my point here is I want to tell the clinician, just take another look at the patient. Maybe this is just eczema, but because I see these features, just take a look, see if it's pityriasis rosea. All right, my apologies, a little washed out. I have fights with my camera from time to time. We don't have a great relationship. But what do people think about the overall pattern here? Low power and high power. Yeah, this is how I get to 54 minutes. Psoriasiform, I agree, there's a component of psoriasiform. And we're looking at the acanthosis, right? And regular or irregular, again, I chose these cases deliberately to be, and spongiotic, I agree. I chose these cases deliberately to not be perfect because it's frustrating when I get taught and everything's perfect and then I go into the real world and nothing's perfect and it's a bit frustrating. So I thought I'd show you at least how I handle these things that are kind of in the middle. So things in favor of psoriasiform, and, yeah, psoriasiform and spongiotic. That's actually you're foreshadowing the way I'm going to dictate this one. And what's in favor of psoriasiform? Well, the granular layer is kind of not there. It is acanthotic, but the scale is quite wet, which, and I'm going to get into another slide which says how you can confound a pathologist by scratching, picking, and rubbing your lesions. And that could happen in psoriasis. You could create a little bit of an ulcer, which could then create a scab or a scale crust and give you kind of a eczematous crust. Also, active psoriasis will be spongiotic, right? You look at the infiltrate, it's kind of everywhere, not really confined to these dermal papillae. There's not really suprapapullary plate thinning. There's even an incipient spongiotic vesicle here and here. I didn't give you the high enough power to look, but if you squint, you'll see some eosinophils. In fact, a lot of eosinophils. And a lot of eosinophils to me really warns me off of psoriasis as the diagnosis. But your comments of psoriasiform, I quite like. So that's kind of how, I don't think I gave a dictation for this one. To me, this is more spongiotic with the psoriasiform as well. And the fact that it overlaps kind of leads to the next slide is that eczema or spongiotic dermatitis is pretty straightforward when it's acute. But when it's been around for a while and the patient's been rubbing it, or maybe the clinician's been treating it, it gets to subacute, which is a little bit less eczematous and a little bit more acanthotic, kind of becomes spongiotic and psoriasiform, to the point where there's a quote in Whedon where he talks about chronic eczematous dermatitis and says it could be subtle or even absent. And right after this, I had a case, I deleted it, but it was one where at rounds, the dermatologist decided it was just chronic eczematous dermatitis. There's no spongiosis at all. There's no way I could have done it as a pathologist. So it brings back to the learning point that you need some clinical information sometimes to make a good pathology decision. So I like the comments. Irregular psoriasiform spongiotic dermatitis, that sounds perfect. This is my one slide I stole from Bologna. One of the challenges in preparing this talk was to delete all my stolen images and replace them with actual cases of my own. This is the one hangover. So here's an acute spongiotic dermatitis, and here's a chronic or subacute spongiotic. And I quite like this one because I find this lower image, if I didn't know if there wasn't a caption right next to it, it would be a little bit difficult. It's acanthotic, maybe slightly irregular, but it's hard for me to tell that this is a spongiotic process primarily. There is maybe a bit of granular layer. Scale is a bit dry, but that happens in the subacute to chronic spongiotic process. And this isn't really the comparison I'm interested in. It's more I replaced this top one now with one of the cases of mine of psoriasis that I think is a good case of psoriasis. And we can compare what's similar and what's different here. So similar, there's acanthosis. There's maybe a dry scale. But what's different, there's hypergranulosis down here. There's hypogranulosis up here. And you might be able to appreciate another subtle feature. These neutrophils escaping up into the superficial epidermis and sometimes in the stratum corneum. It's a good feature. Neutrophils in a dry scale. Good feature psoriasis. Also, see these tortuous dilated vessels here and a thin suprapapillary plate. Whereas these ones, it's always the eye of faith in pathology, right? These are actually, there's many cells between the tip of the dermal papilla here and the end of in this granular layer. So, and I put some things down here to kind of summarize what we're saying in words. And then in bold, some of the things that I count on maybe a little bit more than other things. The granular layer I look for, unfortunately, that can even betray you, because you could have psoriasis and then rub the psoriasis and create a little bit of like lichen simplex chronicus. It could be frustrating. If patients just wouldn't touch or scratch their lesions, we'd be home free. Here's a list that compares. I won't go over it, just to point out, as I've mentioned throughout, there are things you can do to confuse the issue. Rubbing, scratching, and partially treating can make things blur together. And I want to spend the time we have, the 50 or 55 minutes, just looking at the pictures and talking about them. So we'll go on to the next one. Here's just a summary of a nice dry scale versus wet scale. And they're not actually wet. The serum is coagulated, so it's dry. But histologically, I think in my mind of this serous fluid as being wet versus just parakeratosis and a flaky skin as being dry. And I chose deliberately cases that aren't perfectly in spongiotic or psoriasiform. This isn't perfect psoriasis. This isn't perfect spongiotic. It probably is a spongiotic case, but a wet and dry scale. All right, here's another case. What do people think here? I'll let you guys teach in the chat forum and I'll just take a break. Yep. Oh, let's see. So here I have some questions here to kind of prompt people. Is there spongiosis? Yeah, I agree. I think there's spongiosis. How about the granular layer? Is it hypergranulosis, hypogranulosis? I feel like this is a bit of a tough one. There's a thickened granular layer here and absence of granular layer thinned over here. The scale may be a bit dry, but I wonder if we go to higher power if there's some serous fluid in there. To my eye, this is more of a spongiotic dermatitis, and this is what happens with the residents too. Some people think psoriasis, some people think spongiotic. I think this is a case that might be a little difficult, and you might have to just describe every feature. And sometimes in my paragraph, I'll say, well, these are 4 features in favor of spongiotic. Here are 4 features in favor of psoriasiform. Maybe if you don't treat it for a little bit and then get a biopsy, or biopsy something that's on another part of the skin that hasn't been traumatized, there's some hints of things you can do to try to help your clinician. I purposely didn't put a report for this because I think there could be a variety of opinions. And that's the other thing. If you send this to an expert, who's to say that expert's opinion is better than yours on something that's kind of on a fence? Yeah, I like that. Spongiotic. The residents in dermatology laugh because the dermatologists love to say things like eczematized psoriasis or psoriasiform eczema. And they can still treat it. They know what to do. So they'll read my report on this and they'll say, oh, that's eczematized psoriasis, if they want it to be psoriasis and use medications that are indicated for that. Or if they want to treat it like eczematous, it gives them all the opportunities. So although we feel embarrassed like we haven't given them an answer, they often like that even better. So don't worry about that. One of the learning objectives, here's some hints for filling out your evaluation that I promised you. Let you read those when you've got your evaluations in front of you. Back to our outline. Here's Whedon's list, all blurred together, of spongiotic dermatitis, and there's a long list. I've covered a few things on that list, and here's a short list of things that I think are common, kind of arranged in order of how common they are. I added a few things that can show spongiosis as a secondary feature, but I don't think it's their primary feature. And we've covered a lot of these things here. I didn't put an infection, but in the cases at the end of my talk, there's a case with tinea, and you can see how that looks. So if it's on that list, it's pretty common. If it's not on that list, it's not that common. And that was one of our learning objectives. And also, if you can have learned something from what I've told you to help you manage these common things, you'll be sending less out for consult. So that addresses learning objective number 1. So we're doing great. What we didn't really cover much is allergic contact and irritant contact. And I didn't really have a case, but last week I got a really nice one. So let's look at this case, maybe at low power and a little bit higher power. So it's a little blurry. I've got a lens issue. As I said, we're having a little fight, me and my camera. So what do people think of this pattern? It's a higher power of one area. Everybody's talking at once. I know you're. Yeah, acute spongiotic. Bolus is a thought because there's a lot of eosinophils in there. Yeah, someone's already on to it could be a drug for sure because there are a ton of eosinophils and allergic contact dermatitis. So drug and allergic contact dermatitis might both be on the differential. The reason I like this one, well, two reasons I like this one for allergic contact dermatitis. One is the clinician said patient exposed to poison ivy is this allergic contact dermatitis, which is awesome. The other is there's a lot of eosinophils, but in addition to being in the dermis, there's exocytosis. It's like they're going out to try to meet something over at the epidermis. There's a little pustule here with neutrophils and a lot of eosinophils in here. Yep, spongiotic dermatitis with intraepidermal vesicle formation and eosinophils. That's perfect. I love it. I don't know. You guys should be teaching. I can just go home. And the other thing I noticed with at least acute allergic contact is it's quite spongiotic. You can see the desmosomes quite clearly. And the eosinophils, so for irritant contact dermatitis, I wouldn't expect so many eosinophils. The spongiosis is usually less. Just refreshing in Whedon's chapter on irritant contact dermatitis. And what he describes sounds to me a little more like what happens when someone freezes a lesion and then 4 days later takes a biopsy, sort of epidermal necrosis and, well, surface irritation and insult to the surface. So there's an allergic contact dermatitis case. And as I mentioned, these are the things that we talked about. And again, needing some clinical help because I would wonder about a drug reaction. I know that I would probably raise a contact issue because of the exocytosis of eosinophils. And again, for the learning objectives, number 3, getting information from your clinicians, especially inflammatory derm. Just some notes on spongiotic dermatitis you can read. I've talked about already that you can change it by rubbing and picking. Talked a bit about, I don't really try to go through all the causes because there's so many causes of a spongiotic pattern. And I leave it back to the clinician to start hunting down, and it makes me glad I'm not a clinician because it sounds like a terrible job. I don't enjoy. And doing drug histories when I say, oh, it could be a drug reaction, and I'm done, but the clinician now has a huge plate full of work. I feel a bit bad, but hey, I chose my specialty. And spongiosis can be a secondary pattern in a lot of these other things, including neoplasms, so keep that in mind. Here's some things you might have learned. So when you're filling out the evaluation, some hints. I know we spent a lot of time on a spongiotic pattern, but I think it's the most important. It gives you a basis for how to deal with the rest of it. It's also the most common. So we'll do a little bit of psoriasiform. We'll start with the outline this time. Here's all of Whedon on inflammatory derm, and there's a long list of psoriasiform dermatitis, or things that can show a psoriasiform pattern. But I'm going to limit it to the things that are pretty common, obviously psoriasis, lichen simplex chronicus. Tinea actually is most commonly, in my opinion, a psoriasiform pattern, and something to think about when you think you're going to report psoriasis to a clinician, something to maybe rule out. And then a few below the break here are some less common things, but things I want to comment or say a few words about, hopefully something helpful. And then a few things that also show a psoriasiform pattern that I didn't give you a case of mycosis fungoides, but I did show in the extra cases at the bottom. You can look on your own. So keep that in mind as well. And these are common. So if it's not on this list, it's not that common. So again, back to the learning objectives, what's common and uncommon. So let's do another case. These aren't that hard because I'm kind of following my script here. What do people think about the pattern here? Spongiotic, vasculitic, granulomatous, psoriasiform, what else is there? Interface. Psoriasiform. Yeah, in fact, you talked about regular psoriasiform. I like that comment because there's acanthosis, but in addition to that, they're all ending really at a nice line here, right? Flaky scale, very dry scale, high power image that I showed for 2 seconds. Again, these tortuous vessels. And little features like that one I pointed out, and I really like this too, is the inflammation tries, in my mind, I feel like they're anthropomorphized. They're like to have human characteristics. These lymphocytes want to go and thin the suprapapillary plate. They don't really care about the tips of the reedy ridge here. They want to get over here and cause damage. And I drill into the residents for extra questions. What if you picked off this scale right here with this thin suprapapillary plate and tortuous vessel right near the surface? You know what might happen in that case? Might get pinpoint bleeding. Anybody know what that's called clinically? And then I get 30 answers from the dermatologist. Oh, spits. So I think it kind of correlates well with the clinical. And then this neutrophils in the superficial epidermis are all really good for psoriasis. So there's one thing I would like to ignore, but there's a glaring eosinophil right in the middle of the photo here. And this just goes to the point that never say never, and you can't count on everything. So although I said eosinophils are very much against psoriasis, sometimes there's the occasional eosinophil, and I'll still think of psoriasis. So for lupus, I don't think this is an interface reaction per se. I think this is just lymphocyte exocytosis in a pattern that's kind of fitting with psoriasis. Also, you can see there's a spongiotic reaction pattern going along with it. So I think that's a good, and here's just a summary of the things that we've discussed. And here's an example of a fairly easy to diagnose both clinically probably and histologically. Lots of neutrophils, very thick scale. It's probably right on the knee of someone who's got very bad psoriasis. Just put this picture because there's these two entities, and I think it's pronounced intraepidermal pustule of Cahoy. That's what I've always been saying. And then there's the microabscess of Monroe. So usually when I think of abscess, I think of it as a clear space filled with neutrophils. In these two entities, though, in psoriasis, I think of it as this, exactly this. The neutrophils are intercalated between the keratinocytes. They don't push away and make a whole nest of themselves. They're just kind of all the way through. And then they don't stop at the end of the epidermis. They continue up into the stratum corneum, also between the parakeratotic layers of the stratum corneum. And usually I see both of them together. And so the residents, I jokingly say, oh, that's the combined pustule of Bradshaw. But I don't think it's going to catch on. So the other pattern, though, if you see this pattern of these neutrophils arranging just like this, this is also exactly the pattern of a tinea infection. So it's something to think about. All right, let's do another case. What do people think about this one? Just checking my time here. So at this point, I start to become impatient when I get my work done. So here's a dry scale. Not much of a granular layer. Yeah, irregular psoriasiform. Some might argue it's right, exactly. Like some of them end a little short, but some of them are going to the same point. So psoriasiform, diminished granular layer, compact keratin, quite a bit of spongiosis though, right? But I said that spongiosis can occur in, especially in active psoriasis. So there's not really suprapapillary plate thinning. So it's not perfect, but there are a lot of features, and I think it's more psoriasiform than anything else. So, and you've mentioned on some of the chat windows before this eczematized psoriasis, or if it was more the other way around, more of a eczema with a little bit of psoriasiform change, psoriasiform eczema. All right, what do people think of this collection of features? Psoriasiform, thickened scale. Yeah, I could think about that. Acroskin's a good thought, actually, because there is a hypergranulosis and hyperkeratosis, and maybe a little bit of a, can't remember, lucidum, stratum lucidum. Yeah, and that's the last one there is what I think this wasn't acroskin, this was, I can't remember where. And when you rub the skin, you get basically these changes. You get a thickened stratum corneum, usually a little more compact than this. And not just So for psoriasis, we want a diminished to absent granular layer, and this isn't diminished. In fact, it's augmented. This is hypergranulosis. The plates aren't thin, they're even thickened, might argue. And another subtle feature, and we'll compare it to, I think I put a psoriasis case here. Look at the tips of the dermal papillae. Here it's kind of blue with the inflammation. And here it's pink with streaks of collagen kind of vertically streaking in there. So that's something that you can have for reference. These can come into the differential because they both have acanthosis and hyperkeratosis, right? But once you get used to it, you see that they are quite different in some of these other features. This is one that getting slightly into the zebra land here, but we'll see what people think of this. It's acanthotic, not super regular. It's a little bit irregular. Any other comments people want to make about this? You can give diagnoses or you can give descriptive features. About the keratin layer. Checkerboard. See, there's always some super smart person in the group that's gonna preempt. So it's hard. I would say there's not diagnostic, right? It's not perfect 6 squares high and 6 squares wide of checkerboard. But there is. It's parakeratosis here, but not here. Parakeratosis up top, or sorry, parakeratosis down here, but not up here. A little more up here, a little less down here. So we're trying to get at, and then the main pattern though is kind of a spongiotic pattern more than, and then when we're looking at for psoriasis, for example, is the granular layer increased or decreased? I'd say in areas it's a little bit increased. It's not perfectly regular for psoriasis. So I think we're looking at that checkerboard, and I actually conversed with the clinician a little bit because I look at this and I look at the requisition, and the patient came to rounds. This one, that's why I included this one in my set, because I actually was able to examine the patient myself. So yeah, is that PGY2? That's awesome. So the best way to diagnose, and what I'm getting at here is pityriasis rubra pilaris. And the best way to diagnose that, in my opinion, is to examine the patient clinically and look for islands of sparing carefully, and really nice, discrete islands of sparing. But of course, the pathologist, that's not part of what we can find. So we really have to communicate with the clinicians. I think this is a hard diagnosis to make alone on path. I know we prepare on exams, but now we're practicing pathologists, we're not worrying about exams. Again, you need some help from the clinician. You can say it's psoriasiform, absolutely, and then list all the features. And if you think there might be a vague suggestion of checkerboard, I think I gave a sample dictation, I might say, for this. Yeah, psoriasiform dermatitis. Say what's accurate and perfectly accurate there in the slide. And then it's like one of those choose your own adventure. There's some alternate endings here. Depending on how many features you have, I'm just checking my time, you can go with some of these things. So I'll leave that with you. This came from a patient who had erythroderma, and that's something that we face sometimes from our clinicians. And I wanted to just say one word about that. It's one of my favorite quotes from Whedon. He talks about erythroderma biopsies have been regarded as largely underwording, variable usefulness, little value, and misleading. And I want to just get on that misleading for a second. I think this references the study that looked at eosinophils in erythroderma, because that's like, so I'll back up a bit. What the clinician is going to try to pressure you to do is tell them this is a drug or this is not a drug. And then you'll look and say, oh, there's a lot of eosinophils. Sure, this is a drug reaction. Or there's no eosinophils, it's not a drug reaction. And what I think one of these studies showed is that they followed up those patients quite carefully and showed that the number of eosinophils present didn't really correlate that well with whether it was a drug reaction or not. And I think that's where he comes at misleading here. So the learning point you can take from this is don't let the clinician pressure you to tell them it's histologic proof of a drug reaction or not. Resist that. Just say, no, I'm going to tell you the features that are there. You can take that to mean whatever you want, but I'm not going to commit. Now, on the other side of it, you can say something useful, because one of the causes of erythroderma is mycosis fungoides. So just to say there's no evidence of lymphocytic atypia can be helpful. And then other than that, I would just say describe it so that you're not misleading, you're accurate, and you can be helpful. Here's another psoriasiform thing. What do people think of this one? I put this one because when I was learning, one of my mentors would always put this in the psoriasiform tray, and we would all get it wrong. I'll see if any of you smart second-year residents. Yeah, someone's talking about SCCIS. That's exactly what's going on here. So you see how everything's very blue? Yes, it's psoriasiform. It's acanthotic. Sometimes it's even more regular than this. There are mitotic figures all through here and some apoptosis. So yeah, this is squamous cell carcinoma. So to get back to this Idiot's Guide to Skin, before you're playing around in these inflammatory derm, just make sure you answer the basic questions first. Look for a tumor before anything else. So here's some things you might have learned. Here's another case. I mentioned before that I look at the cases before I look at the requisitions. And this is a pattern I see. And what happens in this irritation between my shoulder blades and my heart sinks, and I think I know exactly what the clinician's going to ask me. And I don't know why, because there's no specific features here. There's vague, broad lymphocytic inflammation with some eosinophils, maybe a little bit of psoriasiform, but not really well developed, some compact scale. See how thick the collagen is kind of in the superficial part? So what I think of, and I wonder if some of the dermatopathologists that I work with, because I show them some of these sometimes blind, and they do the same thing. They say, oh, I bet the clinician is asking about mycosis fungoides. And I'll look at the records. In this case, that is exactly what they're asking about. And so what I do is I look for any evidence. I mean, look at high power, examine the lymphocytes, see if any of them are cerebriform. Look if there's any junctional tagging or if there's a lot. I'd like to see a lot before I give them a diagnosis, because I think if you say, I don't see any evidence, it's, you at least have the option open that later on it might turn out to be mycosis fungoides. But if you tell it it's mycosis fungoides without enough evidence, you've committed and it's hard to backtrack. So in this case, there's certainly not enough evidence. Yeah, subacute eczema is a good thought. Drug actually totally could fit with this. Another category that I would put this into, and the clinicians actually like this, is, well, and I'll show you when I give you the example dictation, which is right here. I just describe it, first of all. The main thing is there's inflammation. I describe the eosinophils and the slate thickening, the collagen, so this is all accurate. And then I say it's not specific, hypersensitive reaction, just like you said, the drug reaction. And then one of the things I'll put in, because they were wondering about mycosis fungoides clinically, and I say parapsoriasis, which this is true. It's a clinical thing. It's not really a histologic diagnosis. And in fact, it's not even a diagnosis at all. It's just a pattern. But I like the word. And the reason is because the clinician then has the go-ahead to treat it as if it was mycosis fungoides, even if they don't have the diagnosis. So this is my standard line that I use. There's no histologic features that go with that. There's nothing that's been defined in any textbook. However, it could be that. And then I used to say, if there's clinical concern for evolving mycosis fungoides, do another biopsy in 6 months to a year, or if it changes. And then I'd get all these biopsies 6 months later that look exactly the same, which were worthless. So I changed it to rebiopsy in a year or two. And now I'm wondering if I can change it to longer. And one of the learning points I'll give you is just, you may have remembered it from your residency, but I'll say it again. Mycosis fungoides sometimes takes years or even decades before definitive pathologic proof becomes available. And don't feel bad. If it's one of those ones that takes a long time to declare itself, it's typically that end of the spectrum is the one that doesn't hurt the patients too much. So say what's honestly there and don't stick your neck out. And here's some hints, some pearls you could use. All right, I don't know how much time, where are we at? Maybe, I can't remember when I started. Who's my moderator who's helping me with that timing? You can give a comment in the chat window, tell me where I'm at.
You're still okay, Scott.
Excellent. So I'm not going to do too many entities in interface dermatitis. I really wanted to spend the time on spongiatic and psoriasiform. But we'll look at a few things. And here's the list from Whedon, and there's 2 columns here of a whole bunch of things that can have an interface pattern. And here's a pleasant short list that usually covers, well, almost everything that I see, actually. It's rarely outside of this list. And we'll go over some of the ones on this list. And again, if it's on this list, it's common. Not on this list, not that common. So here's one. What do people think here for the pattern or for the diagnosis? We obscure the junction, can't see it very well, maybe a little bit acanthotic, wedge-shaped hypergranulosis. Yeah, interface, and not just interface, but lichenoid interface, as Matthew's saying. Lichen planus, the compact keratin, a little bit too much keratin, but notice there's not really any parakeratosis. So you might ask, why couldn't that be a lichen planus-like keratosis? That's even more common. It totally could be. That requires some clinical correlation. There's just one lesion. And I'll point out that lichen planus-like keratosis doesn't have to have parakeratosis. It could be this. But if there is a little bit of parakeratosis, that's kind of against lichen planus. That's not so common. Another case. People think the pattern, a band, and jagged. Yeah, it's another lichen planus. So the main thing I do to the residents is I give them 2 or 3 entities of the same diagnosis in the same test, and then they get confused thinking, well, he couldn't have put the same one over again. So here's some notes on vacuolar versus lichenoid, because someone said that was lichenoid interface. In my opinion, there's always a bit of both, and I'll show you an example of that later on. And here's just some features that if the clinician really wants you to tell them if it's vacuolar or if it's lichenoid, you can pick one over the other. But I want to spend time on the pictures. So here's, in my opinion, a really nice, you see the little white spaces vacuolar and more of a band and jagged sawtooth, disrupted interface, really. Here's one I think is a good combination. You can see the vacuoles, but also it's jagged and interface. Wedge-shaped hypergranulosis, anybody for diagnosis? How about lichen planus again? How about this one? This is getting super mean because it's another lichen planus. So I just gave a few examples because I find in textbooks they give one picture. It's nice to see a bit of a range from a bunch of different cases. Here's another one, bit of a lichenoid reaction. Any thoughts here? So the thing is, again, don't get stuck on the interface. Yeah, exactly. This is an actinic keratosis. You can see the atypia along a line in the epidermis. So before you get into your reaction patterns, make sure it's not cancer or precancer. These two, believe it or not, are from the same patient. This was just taken a different day with a different lighting. And we're running out of time a little bit, so I'll just kind of talk it through. There's a bit of interface, vacuolar interface, simplified epidermis. But it's deep, right? There's deep inflammation, perifollicular. Also, look at the eccrine structures, perieccrine. Maybe there's a bit of mucin on my colloidal iron stain. Any thoughts? Yeah, it's a pretty good example of lupus. But I don't say lupus. The clinician always says, rule out lupus. My diagnosis is connective tissue disease because I don't know if it's dermatomyositis or mixed connective tissue disease. Or, and I've been burned by this a couple of times, a lupus-like drug, and they stop the drug and their lupus goes away. Here's the features that we mentioned a little bit. Basement membrane thickening is a good one to look for. And again, a sample micro and a few alternate endings depending on how confident you are. And I really rarely say in here, in fact, I don't think I ever say connective tissue disease as a diagnosis. It's just very suggestive of or very consistent with, but they need to do some blood work and other things. So some more hints for your evaluation. This is a good interface here because it has a combination of interface plus a dirty horn. Yeah, well, don't worry, we'll do our 2 minutes. And I find that the only thing that overlaps with this dirty horn and interface is really a pityriasis lichenoides. Here's a mnemonic for that. And I don't really commit to PLC versus pleva, although they have slightly different features, more brisk in pleva, because I think it's better determined clinically. Here's an example report for that. The last interface one, anyone know what this one is? The residents remember this as red, white, and blue. And in the early part, it starts out as an interface and becomes like this, lichen sclerosis, exactly. Now, the reason I put this, I put another case, this is from the same patient. Sometimes this homogenized collagen layer isn't perfectly developed, in my opinion, and it's still, I think, lichen sclerosis. So I wanted to put that picture in. And last one, see the vacuolar interface and a lot of pigment. What color is that pigment? It's red. Do humans make red pigment? No. This is a tattoo reaction. And often a tattoo reaction will give you a vacuolar interface. And usually red pigment is the one that'll do that. So we've covered off a lot of interface. I was just going to give you a list of some things that happen commonly. They biopsy something for basal cell, and it turns out to be acne or folliculitis or ruptured cyst, ruptured follicle or rosacea. And then if people traumatize or lick their lips or pick their skin, these are super common. So look for the donkey before you look for a zebra. And then my last list is a list of invisible dermatoses, and just a case to lead into that. It's a perianal warty plaque, which I guess you could say was verruca or condyloma or something. But I noticed right in the center there's this really nice cornoid lamella, and elsewhere on that same patient's skin is a very nice cornoid lamella. And I found this reference that has genitogluteal porokeratosis, which can be very verrucous. So I guess that's a common diagnosis with a bit of a zebra skin painted on it. And here's the list of invisible dermatoses. Just if you're stuck, go through that list and see if it's there. All right, so I covered off those things and I went through the learning objectives. Thank you all so much for your attention. If there's any questions or if I have any time left, we can do any questions.
Okay, thank you very much, Scott. So if anyone has any questions, we have about 5 minutes for some questions for Scott. You can just type them in the chat box or the Q&A box.
Yeah, and while we're waiting for you guys to,
Yeah, an excellent presentation. You know, it can be so challenging to have an interactive session in Zoom, and you did a really great job for that. And I think everyone also appreciates the comments, how you write your comments, and microscopic descriptions. It's always really challenging what to put in there. So it's very helpful.
Yeah, I actually made a pact with Victor Tron that I wouldn't ask him any questions and he would hang up before I started talking, because I don't want a bunch of very knowledgeable people looking at my halfway cases and saying, oh, I think you're wrong, Dr. Bradshaw, I think it's this. But if I'm wrong, you know, you can tell me privately. Just a few extra cases while we're waiting for questions. And if you have questions,
there's one question here.
Okay.
What do you do if you don't get any clinical information? Do you just give a list of possibilities?
So usually what I do, well, always what I do is the diagnosis is perfectly accurate. So if it has to be descriptive, it has to be descriptive. And I just say there's spongiosis with some features of psoriasiform, or there's some interface or whatever. Describe it accurately. And I usually don't give a list because I know it's kind of, my problem is, I don't know what that Shakespeare play where they invited all the fairies to the party and forgot one, and then they caused all kinds of problems. So if I give a list, I'm going to forget one in my list, and I hate doing that. So I usually don't give a list. I usually say this is non-specific, or this pattern can have a number of causes, which is mean, but I mean, it's up to them. If they, sometimes they'll email me or text me and say, oh, what do you think of this? The patient has this feature. And then I'll give them something more specific. But usually, no, I don't give a list. I just say it's not specific. There's no more, well, while we're waiting for people to come up with things to say, here's just some extra cases until we run out of time.
Sure.
Any thoughts here? And this is one of those where there's just not much going on. The epidermis is probably was damaged at some point, but now it's done. And all you got left is this pigment in the dermis. I call it pigmentary alteration because if it's a dark skinned person, you can depigment their epidermis and put it down here and actually make it lighter instead of darker. We're just waiting for questions.
Well, there's a couple more minutes for some questions.
Sure. And you can type whatever you think is going on here. Oh, there it is, hypersensitivity. This is a good one because it's kind of that vague mixture of not quite interface, but not quite not. A lot of eosinophils. Hard to place the pattern. Oh, but it wasn't because this is the PAS on that same case. And there's tinea.
Yeah.
There's another one, subcorneal pustule maybe. Few eosinophils, neutrophils. Again, that one was tinea also. this one we covered. Anybody, any smart second year residents want to tell me what kind of keratin layer we've got going on here? Mound here, spongiotic. Yeah, mounds of parakeratosis. This one's lifting a little bit, and there's incipient vesicle, so that's good for pityriasis rosea. Another porokeratosis, which can have a lot of different looks. It can be a bit warty. It can be very inflamed in the middle. It can really have very little going on as far as inflammatory. All right, I think that's enough. I'll stop my share. Thank you again. That was really...
All right, thank you very much, Scott.
Thank you so much. It was a really great presentation and nice to meet you and know that you have such a diverse background. That's really amazing. I always like people who have very general background.
Oh, thank you. Next time, maybe I'll give how to use technology and pathology to make your life easier.
Oh, wonderful. You're invited. We count on you. Okay, perfect. This concludes our scientific and educational program, and all of you should receive evaluation forms either through the chat or through the email. And now we will move to the OAP general meeting. I will kindly ask you to consider to contribute to OAP membership. This meeting is free, as you know, but we will really appreciate if you can pay your OAP membership dues, and we'll have additional meetings throughout this year. And also after the OAP general meeting, we will have exhibit hall. Please consider joining our exhibits and thank them for all they do to support our organization. So I can see the slide deck is here. Okay, perfect. Heather, maybe because I have also...
what I'm going to do is I'm just going to walk you through the slides then, because I will also launch the polls.
Okay.
I think that will help.
Okay, so let's move on.
Okay. So we want to go ahead and go through the agenda then.
Yes. So let's go to call AGM to order, everyone. And let's move on. So we'd like to move the 22 AGM agenda. And who would like to second?
And just raise your hand. Or you can verbalize. And Meredith, are you able to launch that poll? Because I'm not able to launch the poll on my end for the motion for the members to vote. And if everyone could just please let us know your vote. The motion is to approve the agenda. And if you can just click on your approved or opposed or abstain, and then we'll close the poll when we have sufficient votes. And Meredith, I'll just rely on you to control that because I'm not able to, unless you make me a host, a co-host.
Is it working?
It is, Dr. Liu. We have a fair amount who have already submitted their poll.
On my end, it's saying hosts and panelists cannot vote. I'm not able to click on the approved.
Yeah, we can move you into attendee if you wish, and then you can vote.
Yeah, I cannot vote also.
It's same for me, Ardit, yeah.
Yeah, panelists can't vote, so if you want, we can move you into an attendee right now if you wish. Okay, so let's go ahead and show that so we can move on. And then we'll move to the next motion.
Yes, please. Move the 2019 AGM meeting minutes to be approved. And we need anyone to second this moment as well.
I did second. Yeah.
Thank you. Perfect. Move on.
Perfect. Thanks,
Great.
everybody.
So I'll ask everybody to tell us if they know of the OAP members who have recently passed away during this year. I personally not aware, but if anyone, please let me know in the chat box or speak up. I think we can move, Heather, and if we hear from anyone. Okay, so now we are to the President reports. So the nominating committee proposed the below slate of officers starting from September 22, 2020. Zuzana Gorsky will be joining our resident, she'll be new resident representative. Zuzana, are you here to say hello and to show your face?
Hello?
Hi. Do you have camera?
I'm turning it on right now.
Okay.
Not
Can
sure
you
if
introduce
can
yourself to all the members?
Hello, everyone. My name is Suzanne Gorsky. I'm a PGY2 anatomical pathology resident at the University of Ottawa, and I'm very happy to be nominated to the board as the resident representative for this year.
Thank you. And the following members have completed their terms. It's Dr. Antje Lefrenie. She was our resident board member. She did exceptionally well, and she helped a lot and supported OAP in different ways. She started essentially working with the media for us, and we hope that Zuzana can do the same support. And Dr. Asghar Naqvi, thank you both for your service to the OAP. So for the 2021, we have the following officers, myself as a president, Dr. Rosal as a vice president, Dr. Dialisi as a secretary treasurer, and we have following board members, Brett Weirley from London, Dr. Nancy Liu from Oakville, Andrea Green from Kingston, apologies for the typo here, Aurelia Basca from Ottawa, Bojana Mitrovic from Sudbury. Zuzana is our resident representative, Sarah James is our PA representative, and Dr. Russell Price is past president. So I'll ask everybody for the motion for the slate. It's, I will need someone to second that.
Sorry, I second.
Thank you. Thank you, Suhas. Okay. So we'll be, our nominating committee is looking for one of the members to replace Dr. Naqvi. And we will be looking also for a nomination committee for the next year. So please email or text myself or any of the board members if you would like to be on the nominating committee, and we'll connect with you. So now I'll ask our E&M, Heather and company, to help us with the financial report and go over the financial activity for the organization. I'll just remind everybody that Ardit is our secretary treasurer, Heather Doe is our manager. We have administrative assistant Jennifer McCann and bookkeeper Pamela Lyons.
Thank you, Dr. Plotkin. So we have had a very successful year in 2019, and our financial processes are such that we have expenses that come into our office. Those expenses are, we initiate a check We provide the backup to Dr. Plotkin and Dr. Elisisi to review and sign, and they approve that, and then we sign it and send it to the recipient of the expense. So it works out extremely well. It's very efficient. We have, as you can see, our revenues from 2019. Conference generated $85,000. It's broken down to sponsorship. We had food and beverage that was sponsored. We had exhibit fees as well as our registration fees, totaling just under $86,000. Our association revenue, our membership just under $18,000, job posting $23,300, for a total revenue of just under $42,000 for our association, and the association and conference combined, almost $130,000 in revenues. You look at our expenses for the conference, you can see a detailed line item of how our conference last year shaped up for our expenses, totaling just under $42,000. Our operations for the organization, you can see those listed there, fairly status quo from year to year without any kind of dramatic change, totaling just under $25,000. So when you add our expenses and our revenue streams, we ended the year with just under $62,000. Very healthy financial position for the organization. As compared to the budget, you can see that we actually did far better than we had anticipated in our budget. Our membership dues was up. Our conference generated a fair amount of revenue because of healthy sponsorship. We had increased website revenue for job postings, and then some miscellaneous interest revenue that we received on our investments for a total of $127,000. And you can see we did much better than our anticipated budget, which is very exciting. And then if we look at our budget for our expenses, you can see that we are also tracking very nicely. We renegotiated our insurance to get a much better package for medical not-for-profit societies. And this meant that our premium went down because we combined all of our insurance into one package. So our premium is just under $2,000. So there's quite a bit of savings there. We also don't require legal or accounting fees because the accounting fees are included in our service to the organization. And then there was no need to incur any legal fees last year. So we did save some money there for expense. Our conference, thanks to the amazing management of our conference manager, Meredith, we really did a fantastic job saving everywhere. That resulted in quite a lovely net income. So our expenses were down, our revenue was up, which is always an excellent thing to have for a society. And you can see that our net income was $50,000 more than what we anticipated for the end of 2019, which is a real success story. So I think everybody should give themselves kudos for that. And Dr. Plotkin-Nordy has identified to you membership renewal and the importance of membership. This year to date, January until now, we actually have had a dip in our membership renewals. I think a lot of people have forgotten to do it in the hustle and bustle of the pandemic. And we're down quite a bit from last year. So we're hoping that everyone takes some time to renew their membership before the end of 2020 to get caught up on their 2020 membership dues, and our 2021 membership dues start on January 1st. So we do count on your support because this is what we use for developing the budget. So that's the finances in a nutshell. It's a good news story. I'm glad to share it with everybody.
Yeah, and I would like to thank E&M and Meredith and Heather for their support. As you know, we as physicians cannot manage finances properly, so we really rely on the E&M completely for the situation. Has been really a success story since we moved with this company. So thanks a lot, Heather and Meredith, and to all your colleagues at E&M.
Oh, it's our pleasure. And I will add another success story is that, as you know, this year we have not been able to do our conference, and it's always a little bit frightening when we can't generate the revenue that we anticipate generating for our budget. I've been working with our sponsors quite regularly, and we are excited to announce the co-develop series, which many of you participated in. The first one yesterday was Sectra. These companies have actually put forth a lot of money to co-develop content for you. This is MOC Section 1 accredited activities. So they follow our standards, they follow their ethics as well. So Sectra, our sponsor Amgen for this meeting, EMD Serono, Pfizer, and AstraZeneca, they have all come forward to support our annual meeting. So we anticipate generating around $25,000 in revenue from sponsors and co-developed sessions for this year, which is almost entirely revenue for the organization because our expenses are so small, given that we have the Zoom platform and many of our physicians are not taking honoraria for their talks. So that's another good news story for us. So what I'm trying to tell our members is that we're going to be okay, even though many of you forgot to renew, we're still finding ways to make revenue to keep this association thriving. So that's another exciting story to share with you.
Yeah, and this revenue really allows organization to survive and to improve the website, to invite speakers that we would like, the best speakers in the areas of interest, and then to continue hopefully with the live meeting in a good location so we can invite you all. So really highly encourage everybody to contribute to the membership for this year.
And while you're talking about that live meeting, I think we should just let our members know what our intentions are for next year anyway. We do have a meeting plan that's face-to-face in the fall next year. We have renegotiated our contract for Niagara-on-the-Lake to have a meeting there in future years. But as everyone knows, the state of this pandemic is an unknown. So maybe if we're back to hugging and kissing in the fall, we'll meet in person. But if not, we're going to continue this virtual platform for everybody.
Yeah, I think especially for the OAP, this is sort of, I always seen the OAP as a very social organization. That's the opportunity for all the pathologists in Ontario to meet and discuss issues and really to know who is a new person and what's happening with others in the province. So I'm really looking forward to the live meeting. But in the meanwhile, I think what we have is also great, and I'm thankful for the let's say, that opportunity to meet with all of you this year, and hopefully, we cross our fingers, we'll go back to live meeting again. Mm-hmm. So I think at that point, it concludes our first day of 3. So don't forget to join us tomorrow on Thursday, September 24th at 12 p.m. We will have an excellent program again. It will begin at the lunchtime, and I'll also kindly ask you to consider joining our exhibitor hall now for 15 minutes, and the exhibitors are waiting. We're really thankful to all our sponsors who are providing support to our organization. Thank you all for joining, and please let me know if I can be of any help. You can either email me or any board member, and we'll address all your questions. I emailed all the questions to Michael Pollanen. I got quite a number of them, and I'm waiting for his response. So hopefully if he responds on time, I'll be able to really answer that tomorrow.
Yeah. And we put the link for the EMD Serrano Pfizer Zoom right in there in that chat box. We're hoping everyone just please join us in the exhibit hall right now. It's really important. It's only going to be 10 minutes of your time, and it's very valuable to our sponsors to meet with you for this this quick exhibit hall experience.
Yeah. Thank you so much, and see you tomorrow.
See everybody tomorrow. See you over there at EMD Serrano Pfizer just now. Thanks, everybody.
Yes, thank you.
Thank you, Dr. Plotkin. Thank you, everybody.